Now it's time for all things mental health with your host, Dr. Nicholas Goodwin. Come on in, take a seat. All are welcome here. It's Health Cafe Radio.
It's been a while, so how the hell have you been?
All right, welcome to Health Cafe Radio. Nicholas Goodwin here, hanging out with Aaron Dilberry. What's going on, Aaron?
Happy Tuesday to you.
Happy Tuesday and happy Saturday to all of our listeners. If you guys remember in the past, Tuesday was a very snowy day with lots of slow, cautious drivers. So I'm proud of Spokane, I guess. I guess there's some accidents, though. I don't know.
I got hit and run the other night.
Did you really?
Yeah. Lady was pointing the other direction on the hill, slid right back into me. Then got out and started dropping F-bombs because she's like, what? Okay. You didn't see me? I'm like, no, ma'am. I was concentrating on the cars in front of me. No, I did not anticipate someone sliding down the hill in the opposite direction and tattooing me.
Did she T-bone you? Is that what happened?
No, it was crazy. She went up on the curb, and it actually wound up not being a ton of damage. But after we worked out with the insurance company and the police department that I was okay to move my vehicle, I moved my vehicle, and she took off. So she thought she was done. Yeah, the police officer came to my house yesterday with like all the report information, telling me, like, you know, if I want to follow up on it, hit and run. So obviously I'm not at fault, but anyway, it was that was a fun evening, and I wound up getting in here to actually produce a Whitworth basketball game with like a minute and 10 seconds to spare before the tip off.
Signing in.
Oh yeah, literally.
The clock ticking in your bag.
Yeah,
it was still jazzed.
It was a very crazy Friday night. Yeah,
for real.
Well, I guess at my age, that's a crazy Friday night.
Oh, man, I had to recover from that. That's wild she took off when the police were there, though. Usually they're just like, they look at the damage and they split.
No, they hadn't come yet. And so I called, and I'm like, can I move the vehicle? They're like, it's up to the insurance, actually. I called my insurance. They're like, if you've already put in the police report, go ahead and move the car. Yeah. And as soon as I did, she bailed.
Dude, it would have been sad, though, if she, like, tried to go back up the hill,
and there was like, and just, like, sitting there spinning, like, oh, now what do I do?
It's like, did she hit run? Yeah, but she's still working on the hill, you know?
Her little Acura is not going to make it up that hill.
You can go chat with her and see if she wants to come back.
Oh, dude, that'd have been the best Friday night ever.
That would have been pretty great. That would have been good retribution there. All right. Well, good. Welcome, listeners. Today I am going to talk about lithium, which is perfect because if you tuned into the sort of the 3 episodes we did on suicide, we ended on lithium in the last episode, talking about its effects on suicide prevention. And we talked for like 30 seconds, and I was like, well, let's go ahead and make that a full episode. Another another big reason why I'm doing an episode on this is because this last week or so I've been studying it and doing a lot of research on lithium. And the reason is because I use lithium in my own practice. I prescribe lithium, and I probably prescribe it more than other prescribers do. I think there's some stigma behind using lithium, and we'll talk about that. But I also use low-dose lithium. I'll use like microdosing lithium, which I learned from Dr. James Greenblatt, who is one of my heroes as far as using for integrative psychiatry. And he talked about using low-dose lithium. And so I started doing it with a lot of the kids that I see just because it has very little side effects, and it seems like a pretty decent approach, especially when the kids are experiencing a lot of symptoms like depression or ADHD or especially suicide. But I was nervous about it because I know that Dr. James Greenblatt, I don't think he's controversial. I think he's very well respected, especially in a specific field, but is not a mainstream psychiatry. And if he would be to be challenged on his approach, he would come with all these hundreds of articles. And I think if somebody challenged me on that approach, I wouldn't necessarily have it other than saying, well, I read 3 or 4 Dr. James Greenblatt books and done a couple of his trainings. But I came across this online blog which redirected me to seems like a not very updated site, and it's called the psychiatryletter.org. Seems like a lot of their stuff is from 2016, but this website was started by Nasir Ghami, Dr. Nasir Ghami, a psychiatrist, Ghaemi, who put out an incredible textbook last year, which is on the website. I put it under resources, and it's phenomenal. If you're a healthcare provider, if you're prescribing psychotropics, you got to get this book. Honestly, it's so hard to read. You read a half page, and you have to go like sleep it off because you've learned so many new things. Well, he has this website called psychiatryletter.org. Like I said, it does not look super updated, but the most recent stuff is probably the most recent stuff is that textbook he put out in 2018. Is why he hasn't been updating his website. But I saw an article. It was that he used to put out. I think it's called the Psychiatry Letter, and from 2016 called The Suicide Issue, and it talks about using low-dose lithium as a preventative measure for suicide. Like, he even puts out the dosing. And I realized that not only was I, that this, highly acclaimed psychiatrist had advocated for using low-dose lithium for prevention from suicide, but he actually recommended using higher doses than what I was using. And I was using lithium citrate because I was able to lower the dose enough, and also the insurance companies a lot of times will cover lithium citrate, whereas lithium orotate, the other nutritional lithium source, is over the counter, but it's not going to get covered by insurance. So I was using that, and I was using, it also comes in liquid, so you can really use whatever dose you want to. I was using 0.2 milliliters, and now I'm using 0.5 milliliters. I was super excited about that, though, because I felt like now Inasargami led me to all of these studies, and I feel like if I were to be challenged on that approach, which I mean is a safe approach, there's no reason to be challenged, but if I were to be, I would be able to show that not only is it safe, but it's evidence-based, and even though it isn't the standard of care, it certainly should be. And so that's what kind of got me excited about talking about suicide. Not suicide, I talked about suicide last time, talking about lithium. And so I'm going to talk a little bit about some other sources I want to shout out, just because there's lots of them, especially if you're interested. There's Dr. James Greenblatt has his own books called The Nutritional Lithium, A Cinderella Story. He also talks about lithium pretty much every single one of his books. We're going to talk a little bit about lithium's effect on dementia today, and he has a book called The Integrative Medicine for Alzheimer's that I would absolutely recommend. Also, if you go to his website, Psychiatry Redefined, you can do his trainings. If you're a healthcare provider, it's a couple $100 to do them, but they're totally worth it. And that's where I got a lot of this, especially a lot of the lithium, not a lot of the suicide information last week. Another book called Lithium, A Doctor, a Drug, and a Breakthrough is by Dr. Walter Brown. This is not a book that I purchased, but I listened to a podcast found on psychiatrypodcast.com. It's a psychiatry and psychotherapy podcast that I listened to in my car. And Dr. Walter Brown went on with the host of that show and talked about the history of lithium, which is fascinating. And so that book is going to go in a lot more detail. So if you like what you're hearing, I would go buy that book and listen to a lot more and read really about the in-depth history of lithium. Another book that I'm going to recommend is offer. It's called The Natural Mental Health Breakthrough by Dr. Mark Miller. I have not finished reading that book. I have I sort of skimmed it in a sense because it's a source on lithium orotate. The reason that I'm making it available is because he breaks down a way to use lithium orotate that he has identified as safe in his own research. And he's not a psychiatrist. I believe he's a chiropractor. And so and he doesn't co-author the book or anything like that, but he's spent years researching it, and so there's reason to believe that he is an expert on it. And so if you're interested in using lithium orotate, maybe more than just using it as a supplement, which I would recommend, you can look at his book and see what sort of options there are there. I'm excited to look more into that book and see what else he has to say on it. So those are the resources that I used for this radio episode, and I will have these all put on my website, goodwinhealthcafe.com. If you go to radio, you'll see this episode. It will be updated by then, and you can look at not only my notes, but look at my references, and you'll have a link there so you can look at the books or possibly buy the books if you are interested. So let's start at the beginning. Let's talk about what lithium is. And if you remember in science school in, 6th grade, you looked at the periodic table. Lithium is number 3, Li's right there, and it is an element. It is a simple compound. It is also a metal. And the term lithia comes from the Greek word that means from rock, and it's just that. It comes from rock and stone, and it's in water. It's in water bodies of water, and as the water erodes the rock and stone, lithium is then released into the water supply, and then the water supply feeds vegetables, and animals eat vegetables, and so we consume lithium in our food, in our vegetables. Eggs have an interesting and significant amount of lithium in it. Most of our lithium comes from, and more predictably, it comes from drinking water. And lithium is dispersed unevenly throughout the world, and some areas have high amounts of lithium in their drinking water, and some areas have low amounts of lithium in their drinking water. And bottled water has no lithium. And interesting, in one of his trainings, James Greenblatt identified that he feels like the bottled water but the increase in bottled water usage he feels has contributed to suicide rates increasing. Now, that seems like a lot. It seems like that's a pretty big statement. However, if you truly believe as the study shows, that lithium in the water can prevent suicide. Therefore, limiting the amount of lithium people get via water is going to increase suicide rates. So the statement is not super far-fetched, even though saying it out loud is kind of like, wow, that's a big statement. So lithium is found unevenly in water, and in the late 1800s, Lithia Springs in Georgia was known for its medicinal hot springs that many presidents, like several presidents, including Theodore Roosevelt, would go to looking for natural remedies and healthcare remedies. Lithium itself was first used as a medicine in 1859 by a doctor named Alfred Baring Garrod, and he used it to treat gout, as he believed gout was caused by uric acid, and he thought that lithium could be the remedy for that. Lithium was advertised in the 1900s as sort of a remedy to lots of different issues, including hangovers. And the first documented case of lithium being used in mood disorders is in Denmark by psychiatrist brothers Friedrich and Carl Lange, or Lange, I never heard it out loud. And they documented it, but when they died, that approach died with them. And so the next time we do see lithium used in mood disorders is in the 1940s by Dr. John Cade, whom is probably the father of lithium for mood disorders. And if you read the book Lithium, A Doctor, a Drug, and a Breakthrough by Dr. Walter Brown, that initially started as a biography for John Cade and then sort of became more of a biography for lithium, as that's a very big story. And so if John Cade was a psychiatrist who actually was in a concentration camp, and he was in the concentration camp as a prisoner, was tasked with running a psychiatric sort of unit where he became very empathetic for people with mood disorders and really identified that there was a lack of resources for people with mood disorders. And so he became sort of the scientist in an age where research wasn't, as hard to do, as it wasn't as scrutinized, and it's good that it's scrutinized because you want to protect people. But so he had some interesting research techniques, one of which came from the fact that when he noticed that his bipolar and manic patients urinated, they tended to chill out a little bit. And so he was interested in that maybe the urine contained a toxic chemical that, when eliminated, improved symptoms. And so, sort of in this, in this crude scientific experiment that he did on the grounds of the hospital he worked at, in his science lab, he injected urine from his patients into actual guinea pigs and would continue to inject the urine into the guinea pigs until they died. And he did find that urine from manic patients killed the guinea pigs faster than urine from not manic patients. I'm not sure, that is interesting, I guess. I'm sure he didn't test, thousands and thousands of guinea pigs where you can say there's clinical significance, where there's, statistical significance there. But it at least it led to the next finding, which was he wanted to see how toxic uric acid was, and so he wanted to inject that into the guinea pigs, and simply used lithium to dissolve the uric acid. So when he injected uric acid dissolved into lithium into the guinea pigs, instead of them getting sick like he anticipated, they got very mellow, and they would just lay on their backs, and they would just sort of stare at him. They would be conscious, but they would be sedated, right? They would be, worked as sort of a hypnotic, which he thought was very interesting, and wondered if there might be the same benefit on patients with bipolar disorder or with mania. So instead of just going straight to the people with mania, he gave it to himself, kind of despite his wife's concern that he was just sort of self-medicating or just arbitrarily giving himself lithium to make sure that he didn't, I guess, die from it, or just make sure he didn't get seriously harmed, and he didn't. So he decided to go and he started giving it to his patients with mania. And the first patient that he gave lithium to in 2 weeks was able to discharge after being in a state hospital for years. And this isn't, this is like a 1940s state hospital. So I imagine this is, you can think of when One Flew Over the Cuckoo's Nest minus 10, 20 years. I mean, you're looking at a different time of hospitalization for sure. So he saw that improvement. And even though the journal that he published the article was not probably the most, it was mainstream as far as psychiatry goes, his design was very well developed. And when you design, a randomized control trial, double blind, there's a lot of scrutiny that people like to make. There's a lot of articles that people will come and they'll just tear apart because maybe they disbenefit from the outcome. Maybe the outcome is showing that the medication that they have spent millions of dollars manufacturing is not effective, and so they'll tear it apart, or they use it to sort of manipulate the findings. Well, he created a very sound trial where he showed the benefit of lithium in mania, and sort of started that train. In the United States, it slowly started to pick up. Psychiatrists started using it off-label. The FDA had not approved it for mania and bipolar disorder until the 70s, and so this is in 1949 that he published his results. And so other countries began to pick up a lot quicker, and they started approving it for bipolar disorder a lot quicker than the United States. But a big issue was that in 1949, the same exact year, a lot of physicians were sort of supporting the stance that sodium chloride or salt is harmful in people with heart disease. And so they were telling people, so there's sort of this widespread, statements that people need to, in general, avoid salt, especially if they have risk or are diagnosed with heart disease. And so so instead of using sodium chloride, they started using lithium chloride as a salt substitute, without realizing that lithium, though is very safe at low doses, becomes toxic very, very quickly. And so there has been cases of toxicity, and there has been cases of death. So there's sort of this sort of stigma on lithium from the same time that lithium was sort of used for mood disorders. And so that's kind of one of the reasons why we think that lithium doesn't necessarily have the reputation it should have. It is still probably has the most abundant data as far as being most effective in bipolar mania. It is also been shown to be effective in bipolar and unipolar depression. It does have some research to support mixed states, and though a lot of the pharmaceutical companies are really fighting against that, trying to say that the antipsychotics are better at mixed states than lithium is. But it is the only medication, the absolutely only medication that with several randomized control trials has shown to treat and prevent suicide. The only medication. There's another medication called clozapine that presented lower degrees of suicide when compared to another antipsychotic called olanzapine. And so that trial didn't show that clozapine treated suicide. It just showed that it had lower suicide when compared to other treatments. Whereas lithium has absolutely been shown to decrease suicide. And so wonder, why don't we use it more often? I'll tell you why. The big thing I think is you sort of have that cultural sort of perspective, sort of even though that scare was 100, not 100 years ago, but 70 years ago, it's still a scare, right? In the 1990s, medications like Depakote for bipolar disorder were heavily pushed and paid for.
I've heard of Depakote.
Yeah, Depakote. Depakote is it's not being pushed anymore because there's the patent is gone and it's now generic and no one's making money off of it. But in the 90s, they were making a lot of money on it. And I have lots of Depakote stories because I gave a lot of Depakote out in the state hospitals as an RN. But it's funny, it came in sprinkles. Like you would open up a capsule and you would put these sprinkles. So you'd have this cup of sprinkles that you'd mix with the food.
Okay, so when you say it came in sprinkles, you don't mean the usage. You mean the actual drug was sprinkles.
The medication was sprinkles, and I saw an old advertisement of these sprinkles like falling on like ice cream, and so I was just like, Depakote now with ice cream. I don't know if that's really what the thing was. Oh my gosh! But it looked like a
Baskin Robbins 30-second flavor.
Yeah, 30-second Depakote sprinkles. So. But I gave lots of sprinkles, man. One time I even gave sprinkles and put it in a tuna fish sandwich, and that because that's where the patient liked it, and that was gnarly, man. It was just all those sprinkles in that sandwich. So that came in the 1990s, and Depakote, man, it worked. It works. You know what I mean? It doesn't treat suicide, but it works for mania and it works for mixed state. It doesn't do great with depression. It's not as well rounded as lithium, and I would say the monitoring is just as hard, and the side effects are probably worse. But it does work, and it's probably underused as well, just because it's not getting, when people are really that sick, when they really have that full-blown bipolar, you really are thinking about using lithium or Depakote. And if lithium didn't work, you should absolutely use Depakote. If there's some mixed state, there's some evidence to support you should go with Depakote. But that's not really ultimately what we're going to talk about, but that's a big reason why lithium sort of declined. Another reason why, the big reason that I see the issue is that the monitoring is kind of a challenge. When I'm wanting to use medicinal lithium to treat mood disorders, I have to make sure their kidneys are good, because lithium is metabolized by the kidneys. And so if I'm going to be giving very high doses of lithium, I need to make sure their kidneys are working. I want to make sure their thyroid is good because lithium could lower thyroid. And then I have to, because lithium can become toxic very quickly, I have to monitor lithium levels. And so I've used it very effectively and very safely, but you just have to maintain that lithium monitoring in order to do so, which can sometimes, or a lot of times, be a barrier to your patients. But other countries, like Europe, 50% of people who have bipolar disorder are using lithium, and in the United States, it's something like 10%, which is bananas that only 10% of people with bipolar disorder are treated with lithium when lithium is the gold standard for bipolar disorder. It's sort of like if you have an extreme bacterial infection or you have cancer, you're going to use the absolute best medication first time. But it's weird that the psychiatry has sort of switched and we avoid these medications that are most effective for reasons like difficulty monitoring and side effects. Sure, but really lithium can be pretty well tolerated. But we're going to kind of go away from the medicational dosing, and we're going to talk more about trace dosing, because that is very interesting and is very safe, and so I think it's very practical for listeners who may not be providers as well. So like I said, lithium is in the water supply, unevenly distributed across the world. It can go into plants and be eaten by animals, and you can get it through eating animals and plants and eggs, but mostly through drinking water. And what they've seen is probably people get about 1 milligram of lithium a day in their diet. And other sources have said people probably should be getting at least 1 milligram. Like as sort of a dietary recommendation, at minimum people should receive 1 milligram of lithium a day. How do you know that happens? You don't know. You can look in the geographic. If you live in North Carolina or Texas or Japan or some places in Austria, you can look at the research and show that there are certain counties that have more lithium than others. I know that Oregon has can have high lithium. So if you live in a high lithium area and you drink lots of tap water, not bottled water, tap water, you can assume you're getting an adequate amount of lithium. Otherwise, you just don't know. You can do hair follicle testing, which is probably the most precise way. It's probably going to cost you $100, $200. But at that point, you might as well just take some lithium. So talking about this trace lithium, I want to bring up a couple of. So they've done research on lithium in the water, and the first one happened in 1970, which looked at lithium levels and overall mortality. And it looked at lithium levels in the water in 100 of America's largest cities. And I found that in the cities that had higher lithium levels, death was less. I don't know how to say that. Related to less death, this is what it says. Primarily from cardiovascular disease. So the studies showed that lithium increased in the water decreased death from cardiovascular disease. Aaron, do you know what the biggest killer in America is right now? I don't know. It's not a trick question. I guess? I'll let you guess.
Okay, all right. The biggest killer in America,
yeah,
I'm going to say is, well, you hinted at cardiovascular disease.
I think it's cardiovascular disease. That sounds right to me. I don't know if I have the data in front of me, but I know that what we've seen is people live longer, but people are dying faster from cardiovascular disease. And so I just saying this out loud, saying that lithium can prevent cardiovascular disease, saying I'm like, wait a second. People are dying from cardiovascular disease, and I'm trying to push suicide, but ultimately, CV as well, man.
That's interesting. I don't know. When people, there's certain things that when we talk about, like, oh, we're dying from, like, cardiovascular disease, I'm not exactly sure what that means. Like,
sure.
Does that mean, like, that's not a heart attack?
Yeah, I think a heart attack. You're looking at cardiovascular disease. You're looking at deterioration of the cardiovascular system.
Okay.
So like cardiomegaly, which is increased heart.
Yeah.
Looking at the veins and vessels are becoming like hard and not like flexible. Like,
yeah.
A lot of plaques.
So see, that's one of those ones where I just feel like when you say they're allowed to put so many different things in that box. Mm-hmm. It's such a general term.
Yeah.
It's like
there's like 100 things.
How many people died from travel accidents last year?
Yeah.
Well, what does that mean? Does that mean slipping in the shower at the hotel or in a car accident? Like,
I know what you mean.
You know what I mean? So, having said all that, I mean, that's just my 2 cents.
When they lump things together and like, look how big this number is. It's like, but you lumped like 8 things in there.
That's what I mean. And I just don't know because I'm always suspect with studies. I was just thinking that aloud because I was just like, oh, I didn't
like I'm talking about how relevant and heavy suicide they are, in dementia. But it's like we just talk about fundamentals, man. Cardiovascular diseases.
Well, it's really fundamental, and you mentioned this on last show.
Yeah.
I'm pretty sure you did, right? Other countries where that there's a higher amount of lithium, like in the water or what have you, right? Like maybe countries that eat a lot of fish, and there's a lot of lithium in the water, and they're getting lithium into their diet, right? They're not dying as often or as soon as we are.
Definitely.
Yeah, so there's probably something to that.
It's interesting because you'll see science be like, okay, and in these countries they eat more this and that and this and that, and they're living longer, and there needs to be more studies to show what is helping them live longer. No, you just said it. Their diets. Like if you just replicated their diet, there's no like there's no like their fish isn't better than our fish. They're if you just replicated their diet, probably would find similar results in Americans.
Man. And I think part of that is we don't understand as the average citizen how strong the lobbies are for certain like food groups, right? Like that's the problem is like we still use that same food group chart that we had like in the 50s or the 70s when I was growing up, right? Where like the bulk of your diet is supposed to be bread.
Yeah, bread.
And we're just like, we've completely like science, but we won't ever definitively in public report that because it will tick off all these people that support like, whatever, the dairy lobby or the beef lobby or the bread lobby, the grain lobby or, whatever. It's crazy, man.
But they'll lose their jobs. It's like, but people will live longer. I'm sure there's other, I don't know.
Yeah. They'll lose their job. Like, wait a minute. You're saying that this guy won't die as soon but he's going to, he's going to lose his job, but he's going to live longer. So he's going to have a longer period of time where he's alive and not working. What is the downside to this?
Or he's working for a fish manufacturer now, right? Now they got more fish. Yeah. And I don't think you can manufacture fish. You probably don't want to farm fish. Fresh fish. Maybe he's, I don't know, solving ecological problems.
Yeah.
That's his new job.
I'm all about these conundrums. I got one for you when we're off the air. It's not related to, I don't want to take us down the trail. It's not related to lithium.
Okay. And so I'm going to talk a little bit about, and so that's, that was done in the 1970s. There's a lot of recent studies that showed current data in other areas that high levels of lithium in the water are directly related to lower suicide rates. We'll talk about that when we come back. I'm going to go ahead and lean into a break.
Hey Spokane, it's Jessica Side with Everreal Real Estate. With Spokane's market gaining national attention, homeowners are looking for local expertise. We know how hard it can be to make sense of the opinions in an evolving market. It's easy to fall into the abyss of a Google search. Everreal can help. For over 18 years, we've been helping buyers and sellers just like you. So don't wait. Pick up the phone and call us at 62-HOUSE. That's 509-62-HOUSE. Mention the keyword radio for a free home warranty on your next real estate transaction.
All right, welcome back to KSBN 1230 AM, the Goodwin Health Cafe Radio, airing every Saturday at 6:05 p.m. Come check us out. Today we were talking about lithium, low-dose trace lithium. Earlier in the show we talked a little bit about the history of lithium. We also talked a little bit about why lithium is not widely used for mood disorders, even though it is evidence-based, and for bipolar disorder it is the gold standard. But we're going to spend the rest of the time talking about what is nutritional lithium and what role can it play in suicide, dementia, and other issues. So there's been about 10 or 11 different studies in the last 50 years that have evaluated trace lithium in the water system that is unevenly distributed across the world. The first one happened in 1970, which we talked about, which showed a general decrease in death itself. So early death and lithium had a converse, correlation. More lithium, the lower, the higher, the lower level of death, and that was mostly related to cardiovascular death. In 1972, a study in Texas showed similar results in people living longer. But more recently, now we've sort of been looking at lithium as a preventative agent for suicide, because suicide is absolutely becoming an epidemic. In 2009, there was a study in Japan that looked over, that had 1 million people that it looked at, and then there are 4 reports from 2011 to 2012 from Japan, England, Austria, and another Texas study. And so there's about 5 specific, or I guess 4, no, there's 5 specific to suicide. All of them had a direct relationship where higher levels of lithium resulted in lower levels of suicide, except for 1. So that's 4 out of 5. The one negative study, however, the levels of lithium that were measured were not as high, so they may not have actually been able to succeed in that study in showing that high levels of suicide relate to low levels of suicide. High levels of lithium relate to low levels of suicide because they didn't actually see high enough levels of lithium. Now, this is this review, this meta-analysis of the studies is done by Nasir Ghami, which I will post these resources online so you can review them yourself. I got all these articles for free on their websites. And so Nasir Ghami's point here is that, okay, so if these, there's different measurements that are being done on lithium in the water, and it can be kind of hard to do. So if we're talking about higher than normal nutritional lithium or lithium sources prevent suicide. So what does that mean, higher than normal? And so if normal is about 1 milligram a day, which the average person is going to get in their diet and in drinking water, and that's going to be different everywhere else, then he stated that about 5 milligrams a day is probably a good amount to say it is higher than normal. So 5 milligrams a day is a good point to sort of start at and say that is higher than normal intake, and therefore, based off of the research, could be preventative against suicide. Fascinating. Very, very cool. So, and if you got to go back to another psychiatrist, James Greenblatt, who uses lithium and trace lithium and nutritional lithium all the time and advocates for it, his argument is that there's actually a lithium deficiency. Because if you follow that same guidelines and that same principle, that high levels of lithium in the water correlate to low suicide rates, then low lithium levels in the water will correlate to high suicide rates or higher suicide rates or higher mortality, okay? And so if you're not getting lithium in your diet, right, and it's not necessarily an absorption issue, which it is with other nutritional deficiencies, then you will have potentially symptoms, okay? So he talks about a lithium deficiency, which is absolutely fascinating. And so treating the lithium deficiency, so let's say if everyone should get about 1 milligram and I get 0 milligrams, then replacing it should help treat the symptoms. Or replacing it plus some could potentially sort of give me a head start to treating these symptoms, okay? And so it's not that some people need 5 and some people need 1. It's probably that most people get around 1 or 2 or 3, and some people get absolutely 0. And so those people who get absolutely 0 that have symptoms likely will stop having symptoms after they get 2 or 3 or 4 or 5 milligrams a day, or a little bit more, okay? And so 5 milligrams a day, which is now considered a high, essentially, quintupling the amount that you should get, based off that 1 milligram sort of recommendation or that, average. But looking at what 5 milligrams of sort of natural source lithium is, there's probably 5 milligrams, there's per 5 milligrams of medicinal lithium carbonate, there's probably 1 milligram of natural lithium. So 5 milligrams of natural lithium equals about 25 milligrams of lithium carbonate. So kind of doing that math with lithium carbonate, usually 600 to 1,200 milligrams of lithium carbonate are used to treat bipolar disorder. That's sort of the average, and that gets you to the lithium level that is treatable for mania. Lower levels are needed, or that level is not needed for suicide treatment. Usually we consider lower levels to 150 to 600. So 5 milligrams equaling 25 milligrams of lithium carbonate. 25 milligrams, it's so much less than 150 to 1,200 milligrams. So even though we're calling this high lithium, in the medicine and psychiatry world, it's still minute and trace levels of lithium. We're talking about very, very small dosing of lithium. So so when you're looking at trying to convert that, if you're going to buy a supplement online, lithium orotate or something like that, about 126 milligrams of lithium orotate equals 5 milligrams. But the bottles usually just say 5 milligrams on it. So if you go to like Pure Encapsulations, which is I usually do, and we're going to get some lithium orotate, 5 milligrams, it'll just advertise as 5 milligrams. And per Nasir Ghami and James Greenblatt's research and education, 5 milligrams of lithium a day could, and per the research, should prevent suicides. Okay, fascinating information. That's over the counter. And so if I were to recommend anything, I would say that is probably safe. I think James Greenblatt, in his book that he released to the public called Finally Focused, he talked about lithium, and he says probably using more than 1 or 2 milligrams probably would justify using a healthcare professional. And so if this is something that you're not comfortable with, you could probably get lower levels to do yourself or talk to your doctor about it. The other author who did the Natural Mental Health Breakthrough, Dr. Mark Miller, you could also get his book on lithium orotate, and he'll sort of guide you sort of into like an algorithm as to when you should consult a psychiatrist or a physician. And my answer is probably, if you're wondering, you probably should do it. The only risk is that the provider you're going to is unfamiliar with these research and unfamiliar with this process, and will be uncomfortable making recommendations if they're not familiar with it. And so you're wanting to sort of screen and vet and finding that psychiatric provider who is knowledgeable or interested in learning about it. Okay. And so in these studies, they've directly related it to lithium, but they've also seen other effects as well. And in the history of using lithium, what they started noticing is when they're treating people with bipolar disorder, is that people with bipolar disorder who use lithium tended to have lower levels of dementia than those people who were not using lithium, were using Depakote or antipsychotics, etc. And so that led to several research articles being done. There's been about 5 randomized control trials which looked at lithium and its role on Alzheimer's. All of them showed some benefit, and several of them showed cognitive improvement. Okay, kind of an issue with this is that nothing has really shown to reverse Alzheimer's or dementia, and so if you're looking at research that is on people who already had pronounced disease process, right, where they are already very symptomatic, you're just not going to see an improvement. And really, when you're talking about pharmaceuticals for dementia, like Namenda, these medications are thought to have slow the progression of dementia rather than treat the symptoms of dementia, if that makes sense. And so the fact that if you take Namenda, you probably are not going to see a benefit. You're going to continue to see a decline, as that's the process of dementia. But if you take Namenda, based off the research, the decline is going to happen slower, right? And there's no way to sort of compare that as a patient, right? You're still a patient with dementia. You're still a family member with a patient with dementia. They get dementia medications. You're probably not going to see an improvement. What you're going to see is a slow decline, and so you're going to have to sort of tell yourself, okay, but if they were not on this medication, this would happen quicker, right? Which is a really hard place to be in, I can't imagine, which is why it can be a devastating disease, not only that it has poor prognosis, but also has shown to cause incredible caregiver fatigue and even increase the suicidality in people who are taking care of people with dementia, with their loved ones. And so, but lithium has been used to show that it has, not only does it have cognitive repairing effects, especially and specifically with people who are at risk so we're talking about people who are at risk for dementia and people with mild cognitive impairment, which is the term used for mild dementia. And so if you can start using this at mild cognitive impairment, or better yet, you can identify a risk for dementia and start using this, that's really where it's shown to shine, that it's shown to decrease dementia rates, right? Not eliminate them, but decrease them considerably, as well as improve cognitive impairment. And so, again, probably lithium orotate 5 milligrams per nosurigami is fine, right? That's probably enough to be sort of neuroprotective of this population, and also enough to be preventative to an extent, right? And also show cognitive repair. There is a product that I will post online called the Luma, L-U-M-A. I think if you just Google Luma, you're going to find it. It is a medical food by the FDA. So it's approved by the FDA as a medical food. The manufacturer is also the manufacturer of Enlight and Embrace, which actually got the classification of medication, but Luma did not get a medication classification. It is a medical food, and it contains lithium as well as several other dementia protective substances, not substances, but chemicals like B12 or curcumin. And what I've noticed is doing research on this is James Greenblatt book, Integrative Medicine for Alzheimer's. If you read that, Luma is essentially all of those chemicals that he talks about into one pill. And so it's just sort of this mega medicine food called Luma. And I would, it probably costs about $40 a month if you're interested in taking it. I would really, you don't have to have a doctor prescribe it. It's medical food. Probably want to keep a doctor on board who knows it, but I would always recommend it for people who have mild cognitive impairment, or if you think you have a risk for it, I say, hey man, start taking it. You might just prevent it, right? Dementia is terrible. So any chance you can get to prevent it, especially something as safe as this, it can be, I'd say go for it. Going back to, its role in suicide and sort of the, in my approach with that as well, I work a lot with younger people. I work a lot with people who use drugs and alcohol. I work a lot with people with kiddos with mood disorders that are very complex, and I tend to work a lot with people who are suicidal. And it's something that I'm passionate about, which is why I spent the last 3 episodes on it. And so with this information, it makes me very comfortable in using this approach where I will use trace lithium, nutritional dose lithium, in order to prevent suicide, right? And we're talking about prevent suicide completions, right? And it's shown to treat suicide ideation as well. But I sort of explain this to the patient. This is not something that you're going to necessarily see improvements with right away. And I've had some patients who have been on low dose lithium after a couple of months, kind of just like an SSRI, respond well to it. But it didn't happen right away. And I'm really talking about the neuroprotective effects on it. There's some research out there. They did a 4-week trial with substance abusing adolescents, and they gave them trace lithium, and it in over 4 weeks showed improvement in the mood. So it can have a short-term effect-ish, but really you're looking at the long-term. And with dementia, it was really the 12 to 15-month trials that showed improvement. So we're not looking at like, we're going to give low-dose lithium for 8 weeks and then call it a failure. This is like indefinite use, right? At least for years, right? That you're going to see this benefit. And if you're talking about protection, you're talking about prevention, right? We're not talking about, okay, well, I think they've prevented it up. No, if the prevention success is the illness not presenting itself, right? And so it's working as long as a person, doesn't have dementia, a person, or has slow dementia decline, or has no suicidal behavior, or decreased suicidal behavior, or hasn't completed suicide, right? That is success of prevention. And so when you're talking about prevention, there's no real comparison there. They're not saying like, okay, well, I gave this medication and after 2 weeks they improved. No, when you're talking about prevention, you're saying, I think we're at risk for this, so we're going to use this intervention in order to avoid that. So as long as whatever that is, whether it's suicide or dementia, has been avoided, as long as it's no longer not present, that means the prevention is working, the preventing is working. And I think that's hard for people to understand. And a lot of my patients have stopped taking lithium because, either they don't see an effect or it's worked. Oh, I feel better now. It's worked, so I'm going to stop taking the medication. But that's not really how the supplementing works. It's preventative, right? We're talking about preventing mental health issues. We're talking about preventing suicide. And so that's something that I think is appropriate, and it's definitely something that I use in my practice, lithium orotate, which is over the counter. If you're a provider out there and you're like, well, how do I, encourage my patients to buy a supplement, lithium orotate, which is, I'm trying to think how much it costs. I think it's about $15 probably if you buy it from, Pure Encapsulations. You can find other manufacturers of it. Pure Encapsulation is sort of advertised to healthcare professionals, and so it has definitely some, a high reputation for its ingredients. Another one that is pretty high regarded is Thorn. So you can, but, I think getting lithium orotate is the safe thing to do. Often it's 5 milligrams is what it's advertised as. But if you're a healthcare provider and you're interested in prescribing low-dose lithium in order to sort of create that suicide prevention or that dementia prevention specifically here, the ways you go about it is so lithium carbonate compared to that is, like I said, about 5 times. So 25 milligrams of lithium carbonate is about 5 milligrams of trace lithium. And so how do I prescribe 25 milligrams of lithium carbonate? There is the liquid formulation of lithium carbonate you can prescribe. There's also the lowest pill you can get is about 150 milligrams. And what Nasir Ghami recommended is giving 150 milligrams and cutting it in half, and then giving it every other day. And that will get you to about 30 milligrams, 30 to 35 milligrams, around that. It's a little higher, but about what that trace level will be. What I usually do is I use lithium citrate, okay, and that comes in lithium citrate. If you're going to get it in milliliters, it comes in a 500 milliliter bottle, which is just a lot of lithium, because every 5 milliliters has about 300 milligrams conversion of lithium in it. So, and And so what I'll do is I'll order quite a bit less. I'll ask the pharmacy to send less than 500 milliliters. Usually I'll ask them to send 2 ounces. And, if you send 2 ounces, and I'll give a half a milliliter. So that's 0.5 milliliters. That is a tenth of the dose, which is the dose supposed to be 5 milliliters. And that gives you about 30 milligrams of lithium citrate. And 30 milligrams of lithium citrate will equal about 5 milligrams of nutritional lithium. That's all I use. I use 30 milligrams. 30 milligrams of lithium citrate, or about 0.5 milliliters of the fluid. That's kind of a standard something that I prescribe for kids with either risk factors of suicide or present suicidality that lithium full dose is not appropriate for. Either they're having to trial other medications, or other medications are working for depression, but the suicide still comes and goes. So that is the recommendation that I've come to. That is something that has been supported by Nasir Gami and also James Greenblatt, two highly regarded psychiatrists. There's an incredible amount of research to support this, and so that is why I use it. Thinking about the risk factors for traditional risks of other lithium, as far as its role on the kidney and the thyroid, and like I talked about before, using medicinal dose lithium, you need to make sure that the kidney is working well. In his book, James Greenblatt talks about how he's seen trace lithium be safe with people with kidney disease. As a prescriber, I would still be very hesitant. I definitely do not have that expertise yet. And so I would recommend working with your healthcare professional or looking at resources to sort of say, hey, I have kidney issues. Am I safe to take this or do this? Likely the healthcare professional will say, if they're familiar with it, will say yes, but let's supervise it. Let's check your kidney levels regularly. With thyroid, with lowering effect of thyroid, it's probably worth still checking your thyroid. And if your thyroid is lowered, it's synthetic thyroid, Synthroid. The body is just as good as normal thyroid. And so supplementing for that can be helpful. If you're somebody who is on, medically dosed lithium for bipolar disorder and you are responding to it, low thyroid is no reason to stop the lithium. You just got to supplement that thyroid. And so those risks are definitely not as high, and that's really a big reason why I'm attracted to this. I just can't put everybody on medicine dose lithium. The science doesn't really support that. And the monitoring is a challenge for some people, and so trace lithium really opens up that door to really help people out. And so the other risk factors of lithium is toxicity. You're not going to see that with these doses. You're going to see, when you measure the blood of somebody who's on lithium, they're going to have a blood level of below 0.2, which is the minimum blood level you can assess for. So if you get somebody on low dose, around 150 to 300 milligrams a day, their blood level will be anywhere between 0.2 and 0.6. And then if you go over 600, their blood level should be anywhere between 0.6 and 1.2. 2 milliequivalents of lithium in a system is considered to be toxic. And when what you really see is increased tremor, you see cognitive changes, and so that lithium toxicity can be pretty dangerous. And so that's why there's ultimately concern with the prescribing, and that's why low-dose lithium can be such a great option. One more thing that's important to talk about lithium is hydration, making sure that you are drinking enough water. As like I said, lithium is excreted through the kidneys. Also, lithium is a salt, and so if you are dehydrated or overhydrated, your sodium levels will fluctuate, which will cause your fluid level to fluctuate, which can create either non-therapeutic levels of lithium, or it can cause lithium toxicity. If you're dehydrated, then your lithium level will go up. So the lesson there is make sure that you stay hydrated. And so that's really my pitch for nutritional lithium. I'm personally totally geeked out on this. I think this is fabulous. I'm very excited that there's so much support on this as far as the research goes. Anybody interested in learning more about lithium or have any questions about lithium, I would encourage you to hit me up, nick@goodwinhealthcafe.com. Check out my website, goodwinhealthcafe.com, and check out these resources that I'm going to post on there. This is phenomenal, and I really hope this starts becoming sort of a standard of care in our treatment, especially kids with mood disorders, because the medications that are recommended for people can be they have lots of side effects, man, and some of these side effects can be permanent. And so I think that considering safe options first is so essential, and especially when the safe options can be absolutely and incredibly effective. And so that's my pitch for that. Next week, I kind of want to start kind of a series on elements and minerals because that's really where my practice is going, and I use lithium a lot. The next one that I'm really excited about starting to use is B12. And so I've ordered injectable B12, like I've ordered like the serum of it, and so that people who have B12 deficiency, I can give them shots of B12 in my office. I am stoked about that. B12 is water soluble, so it's very hard.
So I need to get on the magnesium and need to get on the B12.
Oh man, B12 is fantastic for you, man.
Okay.
Yeah, dude.
And the omega-3s.
Omega-3s, dude. I love me some omega. That's why the fish is so good, dude.
Magnesium, B12, and omega-3s, and I'm home free.
You're home free, man. That's gonna be it for you, man.
Cool. Do I actually have to get up and exercise, or will these things take the place of exercise?
Oh, I don't know if they take the place of exercise.
Dang, Nick, you haven't solved my actual dilemma.
I think that, but exercise can be something like walking for 45 minutes 3 times a week. We're talking about mental health exercise. 45 minutes a week of mild to medium exercise. Just walking can really do a huge amount of difference. If you're talking about getting swole, you're probably gonna have to do a little more than that. You know what I mean?
No, I just need to get in shape for Southeast Asia.
Yeah. You might have to do a little jogging or something like that. You have to make it a little more dynamic than that. So next week we're gonna talk about B12, and then hopefully the week after that I want to talk about niacin. Niacin is B9. Niacin is fascinating because it causes the niacin flush. Have you heard of that before?
Yes.
Yeah, dude. So me and my buddy, who's a nurse practitioner, we both tried niacin out, and we kept on taking a dose until we got the flush because I was trying to explain it to a patient. I'm like, I don't know how to explain this. So I experienced it. It's safe to have, and we didn't take unsafe dosing, but I felt like I was on fire, dude.
Okay, so then something else. Then I thought niacin is people take that to clear out their urinary tract and all that kind of stuff.
Yeah, I could try to beat a drug test or something. Yeah. There's been cases of that too. So we'll talk about that during that.
Okay.
Where people took extraordinary amounts of niacin and got liver failure. So.
Yeah, I've heard of niacin and vinegar. Back in the day, I remember guys that in school trying to pound the vinegar and then they're throwing up because they can't. Yeah. They're like, I gotta drink this entire. If I drink this entire bottle of vinegar, I'll be clean. I'll be like, I'm pretty sure you're just piss vinegar, but I don't know.
Yeah, they're gonna smell it and they'd be like, nah, we're gonna go with the next person. Don't even bother. Dude.
Yeah, whether you're on drugs or not, we don't want somebody smelling like vinegar around here.
Yeah, that's weirding us out, dude. So, all right, that's what I'm saying about that. You guys have a great week. Check me out Saturdays 6:05, KSBN 12:30. This is Nick Goodwin, Goodwin Health Cafe, signing out.